Welcome back. I hope everyone had a great lunch. I'm Angela Bradbury, come from the University of Pennsylvania, and I'm here to moderate today's session on ethical challenges of genome-based cancer research. I'm just going to let a couple more people trickle in and take their seats while we pull up some slides. So we have a great panel with us today. I'll just introduce you to them briefly, and then I'm going to give a short introduction and introduce the different topics that we'll be covering. We have Gail Jarvik, who's a professor and head of the Division of Medical Genetics at the University of Washington School of Medicine. We have the pleasure of having Ellen Wright-Clayton here, who's the Craig Weaver Professor of Pediatrics and Professor of Law from Vanderbilt Center for Biomedical Ethics and Society. And we have Jeffrey Peppercorn, who's director of the Duke Cancer Survivorship Center and is Associate Professor of Medicine in the Division of Medical Oncology at Duke University. As I said, this is session 3, so today we'll be talking about ethical challenges of genome-based cancer research. I'm going to give a short introduction, and then we'll have each of the panelists give their presentations as well. Similar to the prior sessions, we are going to hold questions until the end, and I'll remind you again, but when we do get to the question and answer session, we do ask that when you come up to the microphone, if you can please give your name and affiliation as this is being recorded. So, ethical challenges of genome-based cancer research. I think everyone knows that we are now in this era of the $1,000 genome. The cost of sequencing has gone down significantly, and this has led to significant accelerations in both genomic research as well as genomic medicine. And this concept of personalized medicine that is very much a reality for us now, particularly in oncology, where we've had a lot of applications come through, both in the germline and somatic settings, where we are using genomics to inform the care of patients. Oh, and I noticed that our panelists are not able to see the slides on this screen. I don't know if that's something that you guys can help with. As I listed just a couple of those applications that are considered to be kind of the evidence-based applications, such as BRCA1 and 2 testing, which has been around for a long time now and has become so much of a standard. And in the somatic world, it includes HER2/neu and EGFR, and more recently BRAF. Testing for BRAF in patients with advanced melanoma. So these really have illustrated the way that we can use genomics and really see personalized medicine in our clinical care. In the area of oncology, there have been several advances in the last couple years that have really, I think, pushed a paradigm change for us, and there are many others here who can speak to this even better than I. But some examples of these include multiplex panels for cancer susceptibility. So we now can test for multiple cancer susceptibility genes. This is not just a simple BRCA1 and 2 or a couple genes related to Lynch syndrome, but now we're talking about many, many genes in one fell swoop. And another change and advance that really all of these come from research into the clinics, but another one that we're seeing now clinically is genomic tumor profiling, where again we can identify molecular drivers of individual cancers and target therapeutics in a way that we hope will be much more effective than our current strategy, where we have a handful of drugs that work for a particular cancer type. So these are applications that have emerged into the clinical arena. They certainly have been grounded and developed first in the research setting, but they're here and they're very prevalent, and so we're dealing with these issues both on the clinical and research side. And just to point out that in cancer, this includes both germline and somatic applications. And this is really a change for us clinically, and it's going to be a change for us in research as well, from single gene to multi-gene and whole genome approaches. And it's raised a variety of benefits as well as a variety of challenges. So certainly there are benefits in gene discovery and coverage. There are time, tissue, and cost efficiencies with these approaches. But there are also various challenges that we'll be discussing today. There are various platforms, so whether you're doing multi-gene panels or whole exome or whole genome sequencing, the limitations and the challenges may vary by the platform. And as you'll hear, I think throughout the day, that context can be very important, and this is one of those contextual factors that's important. Interpretation is a major challenge as we move into more expansive sequencing. And this is something that even if the cost of sequencing may have declined, the cost of interpreting and the efforts that go into that are still huge. Uncertainty, we've certainly dealt with uncertainty before, but we are going to be dealing with uncertainty to a much greater degree as we move into this multi-gene and whole genome applications. And there are questions about how much uncertainty patients are willing to tolerate. And then certainly, which I think everyone's aware of and we'll talk more about today, the risk for secondary information and how we handle that. I won't go through all the different ethical, legal, social issues in genomics, but just to point out that they exist both for the clinical arena as well as the research arena. Only the obligation to return individual research results on this list is specific to the research arena. And these we will be discussing several of them today. I put this slide in because, you know, this is all coming to us, and the question arises, are we ready for it in the clinical setting? And many have argued that physicians are still a long way from submitting their patients' full genomes for sequencing. We don't have the capacity yet. While the price may have come down, interpretation, and there are various other factors that are barriers to us really doing this on a kind of uniform scale within the clinics. That being said, in oncology, we are certainly seeing a lot of these applications come. And so the reason I bring this up is that research, where a lot of this has actually started, is a really great place for us to start thinking through many of these issues of secondary information, of uncertainty. So it's in the research setting that we're going to be able to really deliberate and hash through some of these challenges, which is ultimately going to help us in the care of our patients. So that's my brief introduction, and just to give you a sense of what we will be tackling within the session, I will give a short introduction to return of individual research results. Gail Jarvik will take from that a discussion, and I think it'll be really great to hear the input and her perspective on actually working with return of results and incidental findings within the eMERGE and CSER consortiums. Ellen Wright-Clayton is going to follow with liability and other challenges, which are a very important component of this as well. And then Jeffrey Peppercorn is going to help us with the use of archived biospecimens and discussing what to do with all of these resources that exist and are available from the past. I mean, we can talk about changing informed consent process and procedures for the future, but we still will be dealing with these resources that are very valuable but patients have consented years ago and may not reflect really what we are seeing today. So with that, we'll move on to a discussion. Thanks. I think you'll just have to flip through. There's another title slide. Just a minute while they pull up the slide set. Yeah, I'm going to be starting, and it's not there. I think Hannah knows where it is. I think that might be the right one that has 24 slides. Just go down halfway through. There's a new title slide that I think will get you to the right place. Return of individual research results in genomic cancer research. We're there. Yay. That's okay. All right. So there has been increasing debate over what obligations exist for returning individual research results, particularly as we've been doing more genomic studies with bank DNA. This has been a debate that's been rising over the last several years. And I wanted to present just the case both for not returning individual research results as well as the arguments for considering a return of individual research results. Certainly when I entered, you know, the standard was we don't. Research and clinical care are different, and that was an existing standard for a very long time. And there's a variety of reasons for that. One is there are concerns about blurring the distinction between research and clinical care, that these are two very separate entities. research is very different in that we're seeking to increase generalizable knowledge, while clinical care is very focused on advancing the care of an individual patient. Another reason to not return individual results are the potential for misunderstanding or overinterpretation of clinical significance, concerns about maintaining privacy and the right not to know. We know even clinically that there are patients who do not want to proceed with genetic testing, and we see this all the time in our clinics. The prohibitive costs of to the research team or to biobanks has also been raised as we've started to think about, is there an obligation to return individual research results? And I think there are also costs about what role the healthcare system and what costs they should bear. And it's also been argued that returning individual research results has a potential to negatively impact research progress, and this would be something that ultimately would not benefit our patients. So a lot of reasons to support not returning individual research results. Nonetheless, there's been, and others can certainly speak to this more than I can, but it seems like there's been an increasing cry and demand for considering returning individual research results for a variety of reasons. Common principles that are voiced as far as rationale for this approach would be thinking about the beneficence of patients, particularly when you're thinking about what a finding that we know in clinical care would really change their management. So things that we would consider actionable, particularly in those settings, principle of beneficence comes up. Other reasons include autonomy and respect for persons. So these are individuals, patients, and participants who have given their own time, biospecimens, and been willing to participate in our trials. And so, should we respect what they've given to us through reciprocity and recognizing their autonomy and respect for persons. And another reason I think in oncology is really that while we like to think about research and clinical care being different, they still are very much intertwined within oncology. Oncology providers are often thinking about research as part of that armamentarium that we discuss with our patients, and you've already heard that patients are often coming in looking for trials as well. So I think it is a particular challenge to think about how we separate these things. So these are a variety of reasons people have made arguments to consider returning individual research results to participants. And at the end, I think where we're sitting right now is this kind of sometimes policy. There appears to be consensus that select results, those that are clearly clinically actionable, those that have been confirmed in a CLIA lab, perhaps there needs to be a consideration of returning those results, ones that are clearly going to change the clinical care of a patient. And I think the other place where there appears to be some consensus is that informed consent in the future, thinking prospectively, should address the return of individual results with individuals who are enrolling in research at this time. But there still are a ton of remaining questions and a lot of challenges to think through. I'm presenting just a couple cases here. These are ones that I certainly hear about these, and I think these are ones that clinicians who work in cancer research are struggling with. And these are just a couple examples. So one example would be participants in a large cancer registry. These participants were recruited over 10 years ago, and at that time, informed consent clearly stated there was going to be no return of results. BRCA1 and 2 mutations have been identified in research labs, and now, BRCA1 and 2 testing is very much a standard of care. And when a clinician has this information on a patient, they feel very uncomfortable with this not going back. So the question is, should individual research results be returned? Does the current engagement or context matter? So if this is a research participant who's engaged with a clinical team, is that a context where there is an obligation to be returning back, as opposed to a research participant who participated in a registry and maybe has no ongoing contact. And I think the question remains as well for the research participant who is still in a registry, and the registry is still having active ongoing participation with that participant and has this information. So does that context matter? I think one of the challenges, particularly in many of these, is that this testing has been done in research labs. These are not CLIA-confirmed results. And if you were to think about returning these types of results, and I've heard this from groups that have really struggled with this, is how would we ever cover the cost of counseling? How would we ever cover the cost of confirmation? Another example would be pancreatic cancer patients enrolled in research. The informed consent in this case includes return of clinically significant results, which is a phrase that's used in a lot of informed consent documents in this type of work, which I think really raises some questions as to what exactly that means. And in this setting, BRCA1 and 2 mutations have been identified, again, in a research lab, and the participants are now deceased. But is there an obligation to return to the next of kin? And who would pay for the return and confirmation testing? And a third case, which I think reflects where we are now, where BRCA1 and 2 negative women, and I'm using BRCA1 and 2 as an example, but certainly this holds for a lot of other scenarios as well, but they enroll in a study to identify other cancer genes. And informed consent, again, includes return of clinically significant results, which is common language that a lot of research programs use. Well, we now have multiplex research testing, and within this testing, we can identify genes that have high penetrance as well as moderate penetrance genes. And some of the high penetrant genes, many would agree, are clinically actionable, but the moderate penetrance genes, it's unclear, but they're clinically available. So if you have patients who are walking into your clinic and participate in these studies and we have this information on them, is there an obligation to return these results, or would it be permissible to return these results? And if so, which ones? Who pays for the return? And does the context matter, the continued engagement with the participant? So I would argue that there still are a lot of, there are many questions here, and I'm going to outline just a couple. One is defining actionability and utility, and I think Gail is going to share some of the work that they've done in the consortiums around this. And does it matter if something's commercially available? So we can come up with our actionable list, but one of the things that's happening clinically is a lot of these tests are coming into the clinical arena before there's proven clinical utility. And some of that is because we're packaging them in with tests that do have clinical utility, but we're running these large panels. So does that matter, and how would a patient think about this? I could be offered this, but you also have these results because I participate in the study. Another question is whether there need to be broader conceptualizations of utility. They've traditionally been, will this change care for the patient? Will it change anything we would do for them? But there are other ways to think about utility, and some of the other studies in genetics have raised this concept of personal utility. And I think where we are right now, there's this question of economic utility as well. So, we have this information. We could say we're only going to disclose the most actionable mutations, but we also know that 2 years from now, some of those are going to move up to the actionable bin. And so there's these questions of economic utility and future utility as well. There's also some data to suggest that research participants are interested in receiving research results. I think there are questions about this data. A lot of them are in hypothetical settings. Some of them are in particular studies where there is a lot of engagement. But for those who are trying to make an argument that they feel that we should consider returning individual research results, there is data suggesting that participants may be very interested in receiving their individual research results, even in the setting where there's nothing that could be done. Again, this could be this concept of a future utility. And even in the setting of uncertainty, which is where we previously would, we think about just sharing just those that are actionable, but what about those that might be actionable in the near future? And is it permissible, or is there an obligation? Do individual participants have a right to this information? I don't think that question is answered by these studies, but I raise it because it is one of the arguments. There's relatively little known about the outcomes of returning individual results to participants. I think there's a lot of work that's ongoing, and I would expect that we will see a lot more data forthcoming. But at this time, there's relatively limited data. We know that when research teams have attempted to do this, that many times they can't reach some of the participants. Only about 50 to 70% of the time are they able to reach participants. Again, context is going to matter. And even when offered to participants, some of them, again, will make the decision not to know, so maintaining that right not to know. Some of them may simply decline results. What I thought was interesting, and I hope we'll talk later today, is that in the studies, some of the studies, they did not offer confirmatory CLIA testing, which I think is a big question for groups that are thinking about and desiring to return individual results. In these studies, satisfaction and well-being were high. Cancer screening behaviors in these limited studies increased post-disclosure, but that was regardless of the test result. So that may just be about engagement or re-engagement with these participants. And as I mentioned, there are other ongoing studies which we hope will provide more data in this area. And I would like to hear more about this deliberation over cost and who pays for confirmatory testing, who pays for these additional procedures of recontacting, genetic counseling, confirmation testing, and the delivery of medical recommendations if we are going to think about this. It's a major issue, and who should bear the cost has not yet been resolved. Is that the research team? That seems impractical. Is it the biobank, or is there a way that the healthcare system can be incorporated so those are shared? And that's one of these questions, you know, if you return individual results, they're not done in a CLIA lab, or is it acceptable to tell a participant you should now go seek confirmation testing when that confirmation testing may or may not be covered through usual care? I wanted to highlight this because, Gail, I think you're going to be talking about the ACMG policy statement, at least bringing it. So I mention it here just to mention that this is a policy statement for clinical sequencing, and there have been questions about whether this policy statement would apply to the research setting as well. This group developed a minimum list of 56 genes, which should be reported as incidental findings. That's separate from individual research results, which would be considered primary findings. But this list is one that one can look to for actionable mutations that would fall under that category of an obligation to return individual results. And the recommendation is that they should be disclosed as incidental findings regardless of the indication for testing, regardless of age, regardless of patient preference. And it does include the normal sample of a tumor normal sequence dyad, so the germline. This has been very controversial, but I think one of the questions is, does this even apply to research? Because perhaps it doesn't, and we want to have our own separate guidelines. Again, that's going to be more Gail's area as she talks about incidental findings. There have also been recommendations that have recently come out of the Presidential Commission for the study of bioethical issues. I mentioned them, but they were introduced earlier. Anticipate and communicate, so I think there's fair consensus that everyone feels that we should be doing a better job of mentioning up front in the informed consent documents what we will be returning and how those costs would be covered. There is a need to develop guidelines and best practices. I don't think anyone would disagree with that. There needs to be funding and research to evaluate the outcomes. Agree, I don't think there's any disagreement there. There's a need for education, and we need to ensure access in a supportive health system. But there still are a lot of questions remaining. And I think we have to think about two of them, not only when there is an obligation, but when is it permissible to return individual research results. For a lot of us practicing in oncology, these are patients who are not only participants, but they're also patients in our clinic, and does that context matter? How are we going to cover the costs? How are we going to handle confirmation in a CLIA lab? Does context matter? And what is the duration of these obligations? These are all still very important questions that we need to answer. So I'm not sure I've given many answers, but I would like to say that there are many questions that we still need to address. And I hope that we'll get to some of those today. So with that, I'd like to introduce Gail Jarvik. Again, she's the head of the Division of Medical Genetics at the University of Washington School of Medicine.